Hello, everyone. I'd like to convene the CTAF public meeting and welcome everyone to our discussion of B-cell directed therapies for IgA nephropathy. I'd first like to introduce our CTAF panel, and I'd welcome them to introduce themselves. I'll start with myself. I'm Elizabeth Murphy. I'm an endocrinologist and professor at UCSF, and I have no additional conflicts to report. Every member of our panel who is present today has met the ICER conflict of interest policy, but when you introduce yourselves, your work, please also note if you have any updates to this declaration, and I do not have any updates. I'll go to Ralph Brindis.
Good morning, everyone. Ralph Brindis. I'm a clinical professor of medicine at UCSF, a cardiologist by training, and I have no updates to report.
Bob Collier.
Good morning. My name is Bob Collier. I'm a patient advocate for over 30 years now, specializing in medical research, turns out. I have no updates.
Felicia Cohn.
Morning. I am Felicia Cohn. I'm the Bioethics Director for Kaiser Permanente in Orange County and a clinical professor at the University of California, Irvine. No updates.
Sanket Dhruva.
Good morning. Sanket Dhruva, cardiologist at UCSF and faculty member. No updates to my conflicts.
Rena Fox.
Good morning, Rena Fox. I'm a professor of medicine at UCSF and a general internist. No updates.
Jeffrey Hodge.
Good morning. My name's Jeffrey Hotch. I'm a professor of health economics and chief of the Division of Health Policy and Management. No updates to report.
Jeffrey Klingman.
Hi, I'm Jeff Klingman. I'm a neurologist at the Permanente Medical Group in Northern California.
Sei Lee.
Sei Lee, professor of medicine, UCSF geriatrics. No updates to conflicts.
Joy Melenkow.
I'm Joy Milnico. I'm a professor emeritus in family medicine at the University of California, Davis, and a researcher. I have no updates.
Kavita Nair.
Hello, I'm Kavita Nair. I'm a professor of neurology and pharmacy at the University of Colorado Anschutz Medical Campus, and no updates in my conflicts.
Anne Raldo.
Good morning, everyone. I'm an associate professor of radiation oncology at UCLA, and I have no updates.
Rita Redberg.
Good morning. I'm Rita Redberg, a cardiologist and professor of medicine at University of California, San Francisco, and I have no updates.
Anthony Sowry. Is Anthony Tony? Sorry. I think you're on mute, Tony.
Sorry. Tony Sari, I represent the National Patient Advocate Foundation, and I have no updates.
Great. Thank you, everyone. Next, I'd like to introduce our patient and clinical experts. Again, I'd love for you to introduce yourself and declare any potential conflict of interest. I'll start with Tony Pisa, who is one of our patient experts.
Hi, good morning. I'm Tony Pisa. I'm living with IgAN, and I'm a volunteer patient advocate with NephCure, and I have no conflicts.
And then Samantha Schweisthal.
Hi, good morning, everyone. I'm also an individual living with IgAN. I am the patient ambassador for Alabama on behalf of the IgA Nephropathy Foundation, and I have no conflicts.
Wonderful. And now on to our clinical experts. I'll start with John Barrett.
Hi, everyone. I'm Jonathan Barrett. I'm a professor of renal medicine at the University of Leicester in the UK with a career-long interest in IgA nephropathy. As you can see, I have multiple conflicts, well, not conflicts, but I work with all the sponsors in this space. So I'm equally conflicted with everyone, but I'm not sure that's going to affect my decisions and opinions today. Thank you.
Thank you. Shika Wadhwani.
Hello, everyone. I'm Shika Wadhwani. I'm an associate professor of medicine in nephrology at the University of Texas Medical Branch. And the conflicts listed, or the companies I work with, similar to John, are listed below, and I don't have any additional updates. Thank you.
Great. Thank you, everyone. And for others on the call that may later be making public comments or participating, please, as a reminder, when you join, introduce any financial relationships with industry or potential conflicts that you may have. Now I'd like to introduce Sarah Emmon, the President and CEO of ICER.
Lisa, thank you so much. And my thanks to Lisa for this is her first chairing of a CTAF meeting. We're really thrilled that Ralph handed off the reins to someone so capable. So Lisa, thank you for being the chair of this meeting. I'm Sarah Iman. I'm the president and CEO of ICER. You're going to hear a lot more from me a little bit later when we talk about the policy implications of what we're talking about today. But today, I'm joined by several of our colleagues. Jason Wafsby from Harvard Medical School served as the evidence author for this report. He'll be presenting the comparative clinical effectiveness in just a moment. Dr. Brett McQueen from the University of Colorado was the lead economic modeler for the comparative value section of our report, which we'll talk about also in a little bit. David Rind, our Chief Medical Officer, served as the senior management team lead for this report, and he will be chiming in today as well. Next slide, please. We like to start off just by making sure we are grounded in why we're here today. There are new treatments for this condition. And when we think about what that means, we can get really nerdy about the effectiveness information and hazard ratios and p-values and cost effectiveness ratios, but we never want to lose sight of the fact that new medicines are being developed to help patients. And so we heard from a lot of patients with this condition throughout our review, and we wanted to share this quote. IgAN is the silent killer, as they call it. The diagnosis process is difficult. It's really scary. When you're in a position where everything is perfectly fine, you're doing everything at the pace you normally would, and when you're told there's no solution, your brain works differently. You are still trying to maintain some level of hope. A lot of those themes are going to come through today as we hear from our patient experts and we hear from public testimony. And it is incumbent upon all of us not to lose sight of the patient at the end of the day who deserves access to these new therapies. And we'll talk a lot about that throughout the day today. Next slide. Because we are here because there's been innovation, which is great. That's what we want out of a healthy ecosystem. And so when there is an FDA approval for a new therapy, or in this case, we've got a couple of new ones, one pending, right? So we have 3 different drugs that we're going to talk about today. FDA approval is sort of the beginning of a next phase of thinking about price and access. And it's another phase of thinking about the risks and the benefits beyond what the FDA judged. How does it compare to what we're already doing in the treatment paradigm? What are the reasonable prices for patients, for the health system, for governments, and what lessons are we learning to guide future actions? So this is an idea of what research questions do we still have? What information would we still like to know so that we can fully understand how these treatments fit into the treatment of IgAN? Next slide. And we do this, and we don't shy away from talking about cost because costs are having a negative impact on our healthcare system right now. I think everyone is familiar with the headlines that are coming through for the ways that increasing costs are straining those with the ultimate responsibility to pay for healthcare. For a lot of us, that's our employers because we get our health insurance through our employers. For others, it's the government. So we're paying for it through not only our premiums, but also our taxes. And we have to remember that when then costs are rising at this rate, we are crowding out money we should have for other priorities as a society. And so we do not shy away from talking about the population health impact of every new medicine that is introduced to the system, because every choice about price and access has implications, not just for the patients with the condition, but for all patients in our healthcare system. Next slide. And that's because we can hold 2 things in our hands at the same time. We can care deeply about the patients and the families who are dealing with IgAN and the impact that the disease has on them and the hope and the promise that new therapies have for them, while also caring about the other people in the healthcare system who have sometimes needs that are not met because of costs. And the fundamental principle of how ICER thinks about fair pricing is tied to the fact that there is a price that we can pay that does not harm those unseen people in the healthcare system. So that theme is going to come up a lot today as we think about our analysis and we think about the choices in front of manufacturers, payers, and other purchasers as they think about making sure that patients have affordable access in a way that is not harming the broader healthcare system. Next slide. And so, who are we and who's CTAF? ICER is an independent nonprofit. We are a research institute that produces this information, makes it publicly available so those with the power to make choices about price and access have the best available evidence, hearing from all of the different stakeholders about a new condition, a new treatment for a condition. CTAF is our independent appraisal committee, one of three, made up of, and you've just heard, experts in clinical evidence evaluation, in health economics, in patient and consumer representation. And they will be voting today on the evidence as presented by our team. They will be having important discussions about ethical priorities and benefits beyond health to help inform the decisions that will ultimately be made about these therapies. Next slide. We like to be as transparent as we ask everyone else to be about our funding. You can see a list of everyone who's given us money in the last year on our website. This is the breakdown of support for ICER's work. ICER's research is supported exclusively through philanthropy. Any money that we get from manufacturers, health plans, or provider groups is firewalled off and supports our policy leadership forum, where we bring together leaders from those organizations to try to tackle the next big thing in health policy. Our most recent published report was on how to pay for GLP-1s. That has legs as a report, as you might imagine. We're still talking about it. We also have here links to our conflict of interest policies, what we are allowed to do as individual employees of ICER, and then what our expert advisors are allowed to do in terms of relationships with industry. Next slide. This report is a long time in coming. It takes about 8.5 months for us to do a report. And that's because we are committed to deep stakeholder engagement and deep public comment. So after scoping what we wanted to do with this report, what kind of research questions we wanted to try and answer, all informed from conversations with clinical experts, patients, and the manufacturers, we put that up for public comment and then updated it. We developed a model analysis plan, again, with deep stakeholder engagement, the opportunity to meet and even kick the tires of the economic model from some of our stakeholder partners was available as well. We the draft report went to expert review. Our deep thanks to those who provided reviews is another opportunity for me to say they are not responsible for anything in the report. The report is only the work of ICER and its collaborators as listed on the report, but we are deeply thankful for the patient and clinical experts who reviewed the draft. The draft went up for public comment. We responded to those public comments and updated the report. That evidence report is the basis of today's conversation. When we're done, we'll have a wrap up of the policy roundtable and policy recommendations that will be included in the final report, which will be out in about a month. But if anyone's looking for a report to follow along at home, you can visit the website under assessments, look for the IgAN entry and see the evidence report there. Next slide. When we are talking about value and we're talking about fair price, we have certain ways we think about it. And it's okay to have a different view of value as an individual stakeholder, as a patient, as a clinician, and how you think about the value of a new medicine. But we take an approach that's rooted in the norms of health technology assessment. That tells us that the things here in green are things that are easy-ish to measure. Maybe we don't have all the data that we want. Okay, that happens a lot. But we are able to say, how much longer do patients live if it's a life-limiting condition on this treatment? How much better is their quality of life? Are they able to return to their activities of daily living? And how much are we spending? And maybe how much are we saving over a lifetime of a cohort of patients with a condition with one of these new therapies? And we can quantify that. But we also know that there are things that are very important to the consideration of value that are harder to quantify, or we have questions about the best way to quantify. And that's where the public deliberation comes into play. And that's why we're so deeply grateful for all of the time that our CTAF panel spends reading the report, hearing from patients, and participating in this meeting so that they can weigh in on benefits beyond health and special ethical priorities, so that those with the power to make decisions about price and about access ultimately have that information available to them as they're making those decisions. Next slide. All right, you've done it. You've made it through the introduction. After I finish up here, you'll be hearing from Dr. Jason Wasphy for the clinical evidence portion, followed by Dr. Brett McQueen on the economic portion. We are thrilled that today we have feedback from one of the manufacturers specifically on the economic modeling, giving our independent appraisal committee an opportunity to talk directly to the manufacturer about how they might agree or disagree with some of our economic modeling assumptions. And we're very much looking forward to that. We'll have time for public comment from other members of the IgAN community. After a lunch break, the CTAF will deliberate on what they've heard, and they'll make specific votes on the comparative clinical effectiveness, the comparative value, benefits beyond health, and special ethical priorities. After a brief break, you'll hear from me again when I'll come back with the clinical experts, the patient representatives, payers, and the manufacturer representatives for a conversation about what we do with what we know now. How do we craft policies that are based in evidence that support fair access and fair pricing for patients? We should be adjourned by 3 o'clock Pacific time today. As I introduce Jason, I also want to have a moment to say we are very proud of being in our 20th year as an organization. So this is 20 years that ICER has been trying to bring together different stakeholders to sometimes have conversations that are harder to have than you might want, because it's important for people with different perspectives to come together to talk about how evidence can lead to more sane policy making. And I'm just really proud of celebrating our 20th anniversary and wanted to make sure that I thanked all of the people who are here today for participating in this report, and especially to our CTAF who have been with us for a big chunk of those 20 years helping us do this work. With that, it's my pleasure to introduce Jason Wasphy, who will be walking us through the clinical evidence. Jason.
Thank you so much, Sarah. I'm Jason Wasphy. I'm a cardiologist at Mass General Brigham, and I'm an associate professor at Harvard Medical School. Next slide, please. I'm really honored to be here. I'm the one presenting, but this really has been a team effort. Avery and Sophia have worked over the better part of a year to tremendous amount of investment in this report, and I've been privileged to be part of the team. These are our disclosures. Next slide, please. IgA nephropathy, or IgAN, is a disorder of abnormal IgA antibody deposition in the kidney glomeruli, leading to inflammation and then damage to the kidneys. About 200,000 people in America have IgAN, and it often occurs in younger people in their 30s and in their 40s. It's twice as common among men than among women, and it's substantially more common among Hispanic individuals, less common among Black individuals, but tremendously more common among Asian individuals in an American context. There's a lot that's not known about the course and the progression because people get picked up at different times, but the exact progression from end-stage kidney disease from the diagnosis of IgAN to end-stage kidney disease is in the order of 15 to 20 years. Next slide, please. In some cases, people have obvious symptoms like blood in the urine, but in many other cases, they don't. It's abnormal serum creatinine, a lab test, or tiny amounts of blood or protein in the urine that are not visible to the eye. They can only be picked up on a urinalysis. When you suspect it, if in the right clinical context, it should be suspected, especially if proteinuria is more than or equal to 0.5 gram a day. The diagnosis is really confirmed by biopsy. And biopsy is also helpful because it provides prognostic information. There's information from the biopsy that can tell you how quickly the patient is likely to progress to end-stage kidney disease, and that may inform the aggressiveness with which you pursue treatments. Next slide, please. There are clinical guidelines from KDIGO that have just come out within the last year, and they emphasize that there are two components of therapy. You pursue two goals in an individual with IgAN at the same time. You pursue these things simultaneously. The first goal is really the topic that we're going to focus on, which is medicines to reduce the production of IgA antibodies that will eventually deposit in the kidneys. There's options like Nefecon, which is an ileal release targeted form of budesonide, a steroid, or systemic glucocorticoids. And there are different guidelines from different clinical authorities about how to think through these agents. There's also a second goal of therapy, and this will not be the main focus of the discussion today, but I just want you to know about it, which is that after IgA deposition occurs, there are medicines that can protect glomerular kidney function after that deposition has occurred. And it's really a more aggressive blood pressure target, as well as different types of agents that interfere with the renin, angiotensin, aldosterone system, in addition to SGLT2 inhibition, which is a repurposed diabetes drug that is renal protective. The overall goal of therapy is to reduce proteinuria. Higher levels of proteinuria mean that eGFR is likely to deteriorate faster. So you want to reduce it to less than half a gram a day, and ideally less than 0.3 grams per day. Next slide, please. We had amazing conversations with patients and patient advocates. It really enriches our work with so much meaning and insight based on their lived experiences. Basically, all patients report some delay in diagnosis that, someone thought it was just a urinary tract infection, blood in the urine, and many years sometimes goes on before people are properly diagnosed. And even when they are diagnosed, it's really hard to find a doctor that knows a lot about this, not necessarily a nephrologist, but a glomerular specialized nephrologist. There's often a thematic trade-off. Again, these are people it occurs at any age, but more often it's in the 30s and the 40s, the early decades of life. And there's a trade-off because people often feel okay at the beginning. Do you want to take a really toxic medicine for the idea that you would reduce the probability that down the line you would end up transitioning to needing hemodialysis? That's a very difficult thing to think through. It's a really tough trade-off. These treatments are immunosuppressive. And again, these are many young people. You can imagine women who are thinking about having children. Some of these agents affect fertility, so it really interferes with those types of life decisions and causes a lot of complications and stress. There's a lot of fear and uncertainty. Again, you can imagine the course of disease is relatively long. So again, there's these really difficult trade-offs that you have to think through about the toxicity of current therapies relative to a really totally changed lifestyle. Because when you get the need for dialysis, all of us who take care of all sorts of patients know this, that it's often several times a week, many hours a day in a dialysis center. It's an entirely transformative change in one's life. As a general matter, when talking to patients, that when they get to end-stage kidney disease, they prefer kidney transplant when it's available, but obviously there's not unlimited supply of kidney grafts. Next slide, please. For our review, we evaluated for people with IgAN the clinical effectiveness of what we're calling B-cell directed therapies. That's the first column to reference the prior slide of the KDIGO guidelines, compared to systemic glucocorticoids, which we identified as a key important comparator for clinical practice, no specific immunomodulatory treatment, and we tried to compare each of the new agents against each other. So we assumed that the second column of that slide, the renal protective therapies, were the same in all the comparisons, that everyone would get those types of treatments. Next slide, please. The main interventions that we identified were sinprelimab, which is an inhibitor of A proliferation-inducing ligand. That just had accelerated approval by the FDA in the late part of this past year. Atacicept, which also inhibits A proliferation-inducing ligand and additionally inhibits B-cell activating factor, which is also called BAFF. That has a PDUFA date in July, so it's not FDA approved yet. And the third intervention is a delayed release formulation of oral budesonide, a steroid, which is targeted to the distal ileum. That has had full approval from the FDA since 2023. Next slide, please. We sought information about patient-important outcomes. And really the most important we found in our discussions with patients is, not surprisingly, needing dialysis, end-stage kidney disease. But we also looked at things like hospitalization, quality of life, serious adverse events, infections, as well as the very common, well-known in clinical practice, adverse effects of steroids. It's very difficult to find data on how often you require dialysis. This is something that can occur over many, many years. So we also looked at outcomes that predict that. So estimated glomerular filtration rate, that is predictive, obviously, of when you might require dialysis, and proteinuria, which is predictive of deterioration of eGFR, which then is predictive of needing dialysis. So we looked at all of those measures as important. Next slide, please. In terms of the clinical evidence, we had both phase 3 and phase 3 trials. As you can see, for some of these agents, we kind of had a pre-specified order because some of the outcomes are available in phase 2 trials only and others in phase 3 trials. So if we had phase 3 data for what we viewed as an important outcome, we used it from the phase 3 trial. But in some cases, when those things were not available yet, we looked to the phase 2 trial for that agent to get that specific clinical variable. And so in the key clinical trials that you see here for the 3 agents under evaluation and the key comparator, they generally enrolled people that reflected the epidemiology of IgAN, people in their late 30s and early 40s, a bit more men than women. There was generally a high percentage of Asian participants. Again, this is a disorder that's more common in Asian individuals. Generally, the eGFR values entering the trial were in the 50s and 60s, and mean UPCR, that's a measure of proteinuria, urine protein to creatinine ratio, were between 1 and 2. Next slide, please. In terms of the trials, it really is challenging to compare effect estimates across trials. That is a theme that I want to be very upfront about. These are different amounts of time. Often the same things are measured at different time points. In some cases, a treatment like in the NEFCON trial, they received 9 months of therapy and then had more follow-up, but weren't receiving the therapy during the follow-up. In other trials, the agent was being given during the entire time of the trial. So it really was a little bit difficult to sort of compare the same outcomes in a similar time point across different trials. But we were able to do that to some extent, but you should be cautious about comparing effect estimates across trials. Next slide, please. And in addition, for systemic glucocorticoids, again, this key comparator, there have been different trials. There have been several trials over many decades. By far, the most authoritative and quoted are 2 trials, the testing trial and the STOP IgAN trial. We decided, and this came up in peer review, and this came up also in public comments, that we decided that the testing trial was the best, most accurate representation of systemic steroids for a couple of reasons. One is that it's only a steroid trial. It wasn't an immunosuppression trial that involved other agents like azathioprine and cyclophosphamide, unlike the STOP IgAN trial. It was also more recent and larger. The testing trial and the STOP IgAN trial were both done in a non-American setting. Testing was done in 5 different countries, mostly, but not entirely, in Asia. And STOP IgAN was done entirely in Germany. The other thing is that testing trial enrollees had higher levels of baseline proteinuria. So again, a different trial population for those reasons. But because this was an isolated steroid trial, because the baseline levels of proteinuria were higher, we viewed testing as a more accurate, the most accurate version of the effects of steroid. We didn't systematically abstract very much older trials, but also the results of testing were directionally concordant with the other trial data that were available. Another note about the testing trial is that it was stopped. Initially, the dose of systemic steroids were higher, but because of adverse effects, they isolated it to a lower dose cohort and reported results separately for the different cohorts. Next slide, please. You can see that, again, one of the really important outcomes was the eGFR slope. So slope is a way to sort of homogenize the different time periods of the change in eGFR. It's basically the rate of change over time. And you can see Again, my caution about comparing magnitudes across trials, but you can see that in general, in the placebo arms of all these trials, the eGFR continues to deteriorate, whereas all of these interventions either stop deterioration, reverse deterioration, or substantially reduce the magnitude of deterioration of the eGFR slope over time. This is true for all 4 of these agents. Next slide, please. And that's also true for proteinuria. You can see in these different trials, the proteinuria levels are cut very substantially by like a third or half. The same measures, again, are used differently in different trials, so that for systemic glucocorticoids, the 24-hour urine protein to creatinine ratio was not reported. But the way that they did report proteinuria was also substantially reduced in the testing trial representing systemic glucocorticoids. Next slide, please. We were very interested in patient-reported outcomes because they reflect the patient experience. There were no healthcare quality of life outcomes reported in the trials for 3 of the agents in sirolimus, abatacept, or the key systemic glucocorticoid trial testing, but they did report in the IgA ARD trial, which represents NEFCON. There were little to no differences in SF36, which is a patient-reported quality of life measure between NEFCON and the placebo groups. And that's consistent with what we think about these agents. We don't think of them as things that improve the quality of life in the moment as much as stop kidney deterioration for the long run. So that was kind of consistent with what we know about the mechanism. Next slide, please. In terms of harms, I think for sirolimus and abatacept, there's really no signal, again, in the limitations of phase 3 trials that haven't gone into clinical practice. So you can't see things that are longer term or very rare circumstances. But in general, the placebo arms had more side effects than the interventions. For NEFCON, again, because it's budesonide, first pass metabolism in the liver, and because of this ileal targeting, you generally think of it as having less side effects, potentially at least, than reduced dose glucocorticoids. But at least you can see here that there's more adverse effects in the NEFCON group relative to the placebo arm. And sort of diving into this question about whether NEFCON really is less toxic than systemic glucocorticoids. Next slide, please. I'll show you the direct comparison. It's really very difficult to say. I don't mean to doubt that. I think NEFCON may very well have fewer side effects than systemic glucocorticoids, but it's really very difficult from the data we have to make that assertion in a rigorous way. Clearly, NEFCON does have some steroids typical side effects, peripheral edema, hypertension, acne, and the way that not only the different trials that we're comparing against each other, but the endpoints that were measured in the different trials are different endpoints. So it's really very difficult to rigorously say how much less toxic NEFCON may be relative to low-dose systemic steroids. Next slide, please. There wasn't really anything for subgroup analyses and heterogeneity, either across sociodemographic factors or higher or lower risk patients for any of these interventions. Next slide, please. In terms of controversies and uncertainties, I think one thing that's important to note is that in general, people entering these trials had relatively high baseline urine protein to creatinine ratios. So these are people with relatively high levels of proteinuria. Again, the goal is to get down to a half a gram or even ideally to 0.3. And so we think, and the clinical experts kind of talked us through this, is that people at lower levels of proteinuria probably still have risk, maybe lower risk, but may need therapy, may benefit from therapy, but how the trade-off of toxicities versus long-term benefit work for those individuals who are at lower risk of progressing quickly to end-stage kidney disease is unclear, but a very important clinical issue. For sirolimus and abatacept, again, these are agents that either are not FDA approved yet or just have been approved by the FDA, so they haven't gone into large real-world clinical practice. So if something's rare or happens over a longer period of time in terms of side effects, we wouldn't know that yet, just because those 2 agents are the newest. Although I'll emphasize there wasn't any signal towards harmful side effects in the trial data that we've reviewed for those 2 agents at least. For the pivotal trial for NEFCON only tested 9-month treatment. Patients may benefit from longer periods of NEFCON or repeated courses of NEFCON. An open label extension that doesn't preserve the original randomization of the trial is ongoing. Experts also just disagree about the role of systemic glucocorticoids, and this came up in our discussions with experts. It came up in the manufacturer's feedback to our draft report. This is an area of high controversy, whether NEFCON, the KDIGO guidelines say that NEFCON should be used over systemic glucocorticoids in any setting in which it is available, referencing countries in which you may not be able to get NEFCON. So it wouldn't be the United States, but the up-to-date guidelines give the opposite recommendation, that systemic glucocorticoids should be considered first line. So we had a lot of feedback that it was improper to even consider systemic glucocorticoids in our report, even as a comparator, but we stayed with it because it's widely spread in clinical practice, and because at least some clinical guidance documents recommend that as the first line treatment. Next slide, please. In terms of benefits beyond health and special ethical priorities, I just say that, this is a really tough disorder to have. I mean, again, people often very early in life, they have to make these very difficult trade-offs between really toxic medicines that really change their lives versus this extremely scary specter of not having your kidneys working and requiring dialysis, or maybe hopefully getting a kidney transplant. But that's a really difficult position to be in. It really changes people's lives, whether they're going to have kids or not, what kind of jobs they're going to have, what kind of jobs can you have if you're immunosuppressed and you're more susceptible to infections. The patients were so clear about this with us, and I just want to sort of convey their life's experiences to this talk. In terms of the race and ethnicity distribution, I referenced this briefly at the beginning, but it's Asian individuals is really the very big thing. They have much higher measured prevalence of IgAN. Hispanic individuals have a somewhat higher, and Black individuals have somewhat lower prevalence. But really, in terms of the magnitude of that, Asian individuals really have a very high measured prevalence of IgAN. In terms of caregiver needs, when someone requires dialysis, the life is totally different, and caregiver needs really increase. So you could imagine if newer options work and people are less likely to end up on dialysis, that may have additional benefits, not only for the patients, but for families. And then in terms of mode of administration, there are currently existing oral therapies, and these are injectable. The two new ones are injectable, so we don't really think that this is going to improve access related to the mode of administration. Next slide, please. In terms of the public comments, I've referenced some of this, but again, there was a lot of pushback about the inclusion of systemic glucocorticoids as a comparator. Some people say, it's so toxic. KDIGO says NEFCON first, don't even put it in your report, but we did persist with it. We appreciated the feedback, but we did persist with the inclusion for that reason, because it's widespread in clinical practice and recommended by others, including up to date. There was some pushback about the external validity of the testing trial. It was conducted in 5 different countries outside the United States, most of which were in Asia. So there were differences in the race and ethnicity proportions relative to an American population. Again, Stop IgAN was in Germany, so there's different problems with representativeness in terms of inclusion in clinical trials relative to an American population. So we persisted with using the testing trial as the main source of data to represent steroids. And then there was some also comments about differences in trial populations impacts the relative efficacy of interventions. 100% agree. It's just really, really difficult to say, hey, this agent decreased this by 50% in this trial. It was only 40% in the other trial. It's just very different populations and very difficult to measure. These things have not been compared against each other. It's really difficult to say which works better than the other. Next slide, please. So in that setting, we have strong randomized trial evidence for synprenlimab, abatacept, and NEFCON, at least versus no immunomodulatory therapy, so no steroids. These are pretty impressive trial data. There's at least a small net health benefit, and possibly with time, there really may be a substantially better benefit of these therapies, especially in terms of important endpoints to patients that are related to later avoidance of dialysis need. Next slide, please. And then in terms of the ratings of sinprilumab, etanercept, and Nefcon, the three newest agents relative to an old agent, systemic glucocorticoids, again, it's just really difficult to know because they haven't been compared to each other. And systemic glucocorticoids do have well-known side effects. All of us who practice clinically have seen these things. So a lot of the benefit of these agents relative to systemic glucocorticoids, if there is a benefit, might be related to avoidance of toxicity. But again, it's very difficult to say that with any degree of certainty. Next slide, please. And then, in terms of sinprilumab, etanercept, and Nefcon versus each other, they really, they all seem to work in our minds relative to placebo, to no specific immunomodulatory therapy, but they just have not been compared to each other. And it's really very speculative to say which one of these three medicines are better than the others. Next slide, please. So thank you for your attentiveness. Again, it's been a privilege for me to be part of this. Again, I just reiterate how much it's meant to have these conversations with the patients. I'm really glad that new medicines are available because these patients need new options and they deserve new options. And I'm tremendously grateful for the partnership of ICER to be able to do this work. Next, or no, not.
I think that's me. Yeah. Thanks so much, Jason, for a really thoughtful and detailed review of very, very complicated situations. So we have lots of times for questions, and I see they're already there. So Rita, why don't you go ahead first?
Thanks so much, Lisa, and I'll add my thanks to Jason. That was an excellent summary of the data. I wanted to get back to two areas that you've mentioned. One, as you said, what's most important to patient is quality of life and not progressing to dialysis, but that wasn't measured in any of the trials. And so I'm interested in learning a little more about the natural history, how long it takes to progress, what we know about treatment, and then how valid is this called surrogate endpoint of reduction in proteinuria, or the UPCR, in terms of predicting avoiding or delaying dialysis. I have a second question, but I think that one was long enough, so I'll wait for the second one.
Yeah, first, and then get to your second one. Yeah, and appreciate your prior. You've given so much thoughtful lectures over the years about the importance of being skeptical about surrogate endpoints. I think the best we can tell, there's a lot of uncertainty about the course. It's probably in the order of 15 to 20 years between diagnosis and need for dialysis, and we do think that these surrogate endpoints are likely predictive of later. But to your point, there's no one who's done a 20-year analysis of actually needing dialysis. I also would just be humble and probably defer to the clinical experts a little bit if they want to add anything to that, because it's so much about the disease itself.
Yeah, so I think John, can you guys hear me okay?
Yes.
John, please feel free to add to this. But ultimately, I think what we know, and there's, really great data that's come out recently that's been alluded to from the UK Radar Registry, and then similar data that has been replicated in the United States, particularly from the Kaiser Group, and in other countries around the world as well. And I think what we've learned is what we thought many years ago was more of a benign disease. The reality is that's not the case. So if you follow these patients long enough, the majority of patients are at risk of kidney failure during their lifetime. And even the patients that we thought perhaps were lower risk based on their proteinuria, the data shows that even patients who have less than half a gram of proteinuria, a significant number of those, will also have the opportunity to progress to end-stage kidney disease. And ultimately, I think in terms of the question about surrogate endpoint, there was a huge effort by, a number of groups, including the Kidney Health Initiative, through the Kidney Health Initiative, which was a collaboration with the FDA and other organizations, that really looked at this question about proteinuria being a surrogate endpoint. And that is, at the moment, the best endpoint we have. It is validated, and it is what we're using in clinical trials in order to, predict these patients' long-term risk. John, do you want to add to that?
Yeah, and
Yeah,
just also
and
speak
particularly,
to,
what do you
because
mean by validated? I'm sorry.
yeah, and I guess because I was anticipating Rita's follow on, because at one point you're saying that the people progress who don't have bad proteinuria. And so then how good is the marker if it goes both ways? So yeah, a little bit about how that surrogate is validated would be helpful, John.
Thank you. So there was extensive work undertaken by the Kidney Health Initiative, which is a collaboration between the ASN and the FDA, looking at all of the data from randomized controlled trials and the predictive value of firstly, a change in proteinuria with treatment and longer term kidney function decline. And there was a very clear relationship, which is why proteinuria has been used as a surrogate for drug approval. And there is extensive data from cohort studies and registries to show the higher the proteinuria a patient has, the more rapidly they lose kidney function. But as we've got more sophisticated registries with more patient data, what has become apparent that even at low levels of proteinuria levels we previously thought were safe, those patients are still at risk of progressive loss of kidney function. So in essence, what we've been promoting is there is no safe level of proteinuria in IgA nephropathy, because even at low levels of proteinuria, there is a significant lifetime risk of kidney failure.
And when you say loss of kidney function, does that include dialysis?
Yes, so this is kidney failure. So if you look at the radar data, we look at kidney failure endpoints in the data, and 1 in 4 patients in radar with proteinuria less than 1 gram will develop kidney failure in 10 years. Bearing in mind, there are only 30 when they come into the registry.
Great. Rita, do you want to just get back in the...
Sorry. The other thing I was going to mention was about the quality of life. It's a real challenge measuring quality of life in IgA nephropathy, which is largely an asymptomatic disease. And the reason most of the phase 3 and trials have looked at quality of life using a variety of measures is that the scores are so low to begin with, it's very difficult to show an impact. The alternative is actually that we can show that treatments that make people feel worse, and there is absolute agreement that systemic steroids make people feel worse, not better. And that has been captured multiple times in studies across all forms of glomerular disease. So we don't have treatments that make people inherently feel better when we use the current scoring systems, but whenever we measure the impact of the use of systemic steroids, they make people feel worse. They generate a lower quality of life consistently and uniformly, not only in IgA nephropathy, but across all other studies where systemic corticosteroids are being used.
Great,
and that's true. That's true in studies of steroids in IgA nephropathy as well.
Great. Thank you so much. We have a whole bunch of questions, so I want to make sure
I'll go back
we
in
get
the
to
queue for the next one. Thank you.
Thanks, Rita. Nina, why don't you go ahead?
Thank you. Outstanding review, Jason. My question is for the clinical experts about NEFCON. This is not the only oral budesonide that's available, and I know this has been studied and used for other conditions, but the oral budesonide, trade name Entocort, also has delayed release in the distal ileum for Crohn's disease. And that formulation is, incredibly inexpensive. For a 9-month course, it would cost $500 versus $120,000. I know we're not talking about the economics in this presentation, but clinically, would there really be any difference expected to be an issue between those two forms of oral budesonide?
So yes, there would be. I think if you're treating Crohn's, you're treating, we know Crohn's is a disease that affects the entire gastrointestinal tract. And we have formulations of budesonide designed for Crohn's and formulations of budesonide designed for ulcerative colitis. So if you have the ulcerative colitis formulation, it doesn't deliver in the small intestine. It's designed to deliver in the colon. If you have the Crohn's disease formulations, it's designed to deliver budesonide across a much larger surface area of the gastrointestinal tract. And the key effectiveness of this treatment is delivering a high concentration of budesonide within a small area, so you get a high tissue concentration of the drug that is then capable of suppressing immune activity in that particular part of the bowel. And you simply don't achieve those local concentrations of budesonide with a formulation that delivers the budesonide over a much larger surface area.
And that's actually tested.
So the key is that there's been no randomized controlled data to show that budesonide, generic budesonide, delivers the same effect as Nefecon. And there have been a lot of studies looking at the dissolution profile, showing that actually the concentration delivered within defined areas of the bowel are very different with these different formulations. And there are reference papers that have been published and peer reviewed that show that very, very clearly.
So it's a concentration issue because both would be delivered in the distal ileum. It's a concentration.
Both would be, so the Nefecon formulation is specifically designed to deliver 90% plus within the distal ileum. The other formulation is designed to deliver budesonide across a much larger area of the gastrointestinal tract, not just that small area. And the reason that area is important is because that has the highest concentration of Peyer's patches and the highest concentration mucosal IgA protein. So it's really just targeting exactly the same drug in a different way to get the biggest bang for your buck in terms of making sure you hit the area that we believe is a major driver for the production of IgA that ends up in the kidneys.
Great. Thank you. Joy. I think you're on mute, Joy.
Yeah, I got it. So I actually have two questions, which is maybe cheating, but see if I can get through them. So the first question is for Jason, and just hoping that you can go over the duration of treatment of each of the three therapies, and then the duration of follow-up for each of those. And is it anticipated that the duration of treatment in the trial is the duration of treatment for future use?
Yeah, I guess just given the nature of the question, I wonder if we can bring up the slide, because there is one slide where this is in detail. But long story short is that everything that we know about, is that possible to bring up the slide? It's slide 27. If not, I can just read off the slide. It's okay, Lisa. I can just read off the slide. So for sinpretlimab and etanercept, the phase 3 trials were 24 months, so 2 years. For Nefcon, oh, actually, thank you. I didn't know it was going to be so quick. For Nefcon, it was 9 months on drug and then 15 months follow-up off the treatment of Nefcon. And then for testing, it was variable, but about 6 to 9 months of treatment with a median follow-up of 2.5 years.
So the treatment period was as long as 24 months with the first two drugs.
That's correct, at least in the phase 3 trials. I think again, the clinical experts could speak more about the speculative comment that I'm about to make, but I think that we imagine that sinpretlimab etanercept could be used for a long time, whereas both the steroid agents would be considered to be used for a shorter period of time, more or less, in terms of how that might extrapolate into actual clinical practice. That was a little bit speculative what I just said, so I'd love the clinical expert's opinion about that.
So yeah, so that actually leads nicely into my second question, which is for the clinical experts, which is in light of this idea of duration of treatment, can you talk about any and I'm asking you to speculate here, adverse effects that would be anticipated in the longer term from each of these therapies?
Yeah, so this is a great question. At the moment, I think both for sibeprenlimab and atacicept, we have data to show that when you stop the drug, the proteinuria rebound, some of the biomarkers rebound, and so they are thought of as they will need to be long-term therapy to continue to have the effect that they've had in the clinical trial. In terms of Nefecon, as I think was mentioned, so the trial, it was 9 months on drug, 15 months off, but then there was an open label extension. And there's an ongoing study looking at, after the 9 month course, continuing it on thereafter. Again, for the reasons that after the 9 months, the proteinuria rebounded. So the thought is if we continue to keep patients on this medication, could they have continued positive effect? In terms of how are we thinking about long-term effects, I think at the moment, the 2 year data is showing us no safety signals, which I think is reassuring. But obviously, we just don't have data looking out at 10 years or 15 years, realizing that, these are often young patients. Are there concerns? Based on, I think, what we know so far, the majority of the adverse effects that we've seen, for example, with sibeprenlimab, atacicept, were really just injection site reactions, redness. Those were the most common. I'm not aware of any, significant infectious concerns at this moment for either of these drugs, but I think time will tell. We just don't have more data at the moment.
And what about NEFCON? Because I mean, it sounds like, oh, we're just going to use it for 9 months, but then turns out maybe we need to use it for longer. So what about long-term adverse effects?
Yeah, no, I mean, you bring up a great point. There is obviously some systemic absorption. It is a locally acting steroid, but we know from the clinical trials that there are patients who have steroid-like effects, and we see this in clinical practice as well. So I think, long term, we're going to have to think about, how long term are we talking about? Are we talking about one option is maybe doing cyclical dosing? So you do 9 months and then you see how the patient does. Maybe they get another course at some point, or you can also think about, doing a reduced dose after an initial full dose. So I think there's ways to think about this. I don't think we have, again, really, really long-term effects. What I think we do know is we don't have direct comparisons, but what we know from systemic steroids, those medications are obviously very toxic and come with, significant side effects. We're talking about steroid-induced diabetes, hypertension, bone loss, all the other different things. So the hope would be that these will be better tolerated in the longer term.
Great. Great. And I'm just we had 3 more questions. Someone dropped off. We only have a few minutes left, so I'm going to move on to Sanket. And Jeff will get back to you if there's time.
Thanks so much, and thanks to Jason for a terrific presentation. One of the things that I'm really grappling with and struggling with is around the standard of care. And while I realize that the KDIGO guidelines don't recommend systemic glucocorticoids and everything that you said, Shika, and I think about the toxicities, and I think all of us who practice clinically certainly agree we don't, patients don't want to take these medications. We don't want patients on these medications. But what I'm wondering is, when I looked at the JAMA study of the testing trial, it looks like there are at least relatively significant benefits in terms of the magnitude of eGFR reduction. The primary endpoint is met in that trial. It seems like we just don't have much data in terms of hard outcomes, again, given that you've explained, we're looking out 10, 15 years. But what I'm wondering is, how do we expect really that this benefit to some of these newer agents will indeed wane over time, that patients must be on these medications? And do we have any signal at all of any potential hard clinical outcome benefit around renal failure, around myocardial infarction, around stroke, around some of these true hard clinical outcomes that we want to avoid? I know it's hard in 2 years, but do we have any signal of that at all?
So there's no signal at all. And if you look at the SGLT2 inhibitor trials, there is zero signal for the glomerular disease cohort because the cardiovascular events are so low. I think you've got to be really cautious about the testing study. If you look at the proteinuria effect, it's all lost by 3 years. Proteinuria is exactly the same as the placebo group. If you look at the GFR effect, it is all lost within 3 years. The rate of loss of kidney function is the same as the placebo. And the testing study did not capture steroid-related side effects. It did not proactively ask about all the side effects that when you listen to the patients on this call, they're going to tell you are the things that impact so negatively on their quality of life. So I think you've got to be really cautious when you interpret the results of the testing study, because it wasn't delivered to the standard of the studies we're talking about in terms of capturing SAEs, capturing the depth of data that you will look at in the context of the phase 3 registration studies.
Great.
So I just mentioned that because you're comparing apples with pears here, and you've got to be really, really cautious, I think.
Great. Thank you. We're almost out of time, but I did want to have, at the risk of us going a little over, and I know, David, you wanted to chime in, but you're okay? Okay. Do you have a quick question, Kavita? And we'll have a quick answer.
Yes, a really quick question in terms of where these new therapies fall in the continuum of care. I think Sankat started to ask that question. We have steroids. We've got other therapies that are aimed to reduce proteinuria, ACEs, ARBs, SGLT2s. And so in the continuum of care for patients who are diagnosed with IgAN, these are therapies, these new therapies, and I'm just collectively including them. They're included when the disease progresses. And so from a payer perspective, would these be first-line therapies, second-line therapies? Where do they fall?
This is my opinion, but I think these are first-line therapies. These are therapies that have the opportunity to stop the disease process. As you heard, we are not diagnosing these patients the day that their disease starts. By the time these patients come to our attention, and many of them have a kidney biopsy, they've already lost 50% or more of their nephrons, which they're not going to get back. So we're already behind the 8 ball to begin with. But as the KDIGO guidelines have shown, we simultaneously need to think about ACE, ARB, ERA, SGLT2 inhibitor, cardiovascular risk reduction, but we cannot forget about the importance of treating the disease and the disease process. And I think these have to be simultaneously. This is not, to me, second or third line after progression. These patients have already progressed by the time we diagnose them. So to me, the minute the diagnosis occurs, we need to be having conversations about looking at, both sides equally and up front and not waiting, because this is how we get to that high risk of kidney failure over their lifetime.
Great. Thank you so much. And thank you for an excellent discussion and to all our experts for sharing their wisdom. So we'll move on now to the presentation of the evidence and economic modeling. So I'd like to introduce Brett McQueen, who is going to share that with us.
Thank you very much. Really good discussion so far, and hope we can contribute to it. So I'm Brett. I'm an associate professor at the University of Colorado. Next slide, please. Joined by a really great team in Mike Antal and Deepika from Colorado, as well as Wuzhang and Marie from ICER. It's been a great collaboration. It's ICER's 20 years. I've been collaborating with ICER for about 10 years. So it's a big year for me as well. Next slide, please. Just want to note, I have no other conflicts to disclose, no one on our team. We do receive financial support to my institution from ICER. Next slide, please. All right, so the aim of this analysis was to estimate the cost effectiveness of atacicept, sibeprenlimab, and Nefecon for IgA nephropathy as compared to systemic glucocorticoids. I'm going to say steroids throughout to be consistent, so I don't have to say glucocorticoids every time. So next slide, please. All right, so ICER presents a concept around unmet need that is a combination of quality and quantity of life using the EVLY, or equal value of life year. And it really is helpful to think about it in reference to other conditions, such as untreated multiple sclerosis. So this is a really burdensome disease that we're dealing with, both in terms of the life lost as well as the quality of life lost in IgA nephropathy. Next slide, please. Next slide. All right, so we are going to be using a cohort lifetime approach from a healthcare system perspective. really as our base case to capture all of the quality of life and life extension changes that last over the course of a lifetime, as well as the impacts to the health system. I will show you a modified societal perspective as well. And our usual outcomes like total costs, quality adjusted life years, equal value of life years are all fairly consistent, along with the incremental cost effectiveness ratios. One clinical outcome to pay attention to, time to end stage kidney disease. That's really going to capture a clinical outcome that characterizes the trajectory of eGFR or the trajectory of the decline in kidney functioning over time. And I'm going to explain that a little bit more on the next slide if we can move there. All right, so moving from left to right, you'll see CKD 1 and 2 are pretty typical in terms of the quality of life of the average American, the healthcare costs, et cetera. But you start to see impacts on quality of life. You start to see impacts on health system costs. And you start to see really significant mortality signals happening in that CKD 3B, 3A, B, 4, and 5. And then, of course, the very burdensome dialysis and transplant on a patient and what that can, the effects that can have. You may notice that we don't have an arrow back to dialysis if there's a failed transplant, but we do model this as an aggregate cost. So a total cost of what would happen if somebody moved back to dialysis over the course of their life. It's just another alternative way that we could model that. This is a really interesting and key way of modeling IgA nephropathy. The reason is because we have all three treatment effects essentially press the pause button on kidney decline. And we can capture that in terms of those effects on quality of life, in terms of the health system costs and mortality effects. So you're going to see that both in terms of how we define the inputs, and then you'll see it show up in the results, and I'm going to point it out over and over again. The last thing to note is there is, of course, a chance of all-cause death that's built into the modeling framework as well. Next slide, please. So our starting state, our baseline for the model is based on the most recent placebo arm of the Nefecon trial. Notice probably the most important thing here. Remember I started talking about how the quality of life and the cost effects show up in the middle boxes of that model schematic. We're starting patients already in 2, 3A, and 3B, so we'll already start seeing some of those impacts show up for patients in that middle part of the diagram that I just showed you. Next slide, please. So we have a number of assumptions that we've made. You can see them all in the evidence report. The first one to note is that you just had this discussion. Treatment with Nefecon is only really applied for 9 months. We give the durability of that treatment effect 24 months. For atacicept and sibeprenlimab, patients remain on that treatment until they reach end-stage kidney disease. I'll point that out again in the results, and it'll be pretty obvious to you. For our off-treatment transition probabilities, we used the NefGuard Part B trial for Nefecon. That's the placebo arm of that trial. And we use that as a common comparator. We saw very similar characteristics across the placebo arm of the other trials. And then for the ability for us to calibrate to on treatment. So how do we take this common comparator and then show different trajectories of eGFR from treatment? We calibrated based on the most recent trial evidence for each intervention. And really what we're doing is keeping the gap in eGFR slope so that the treatment either flattens the slope for the on treatments of eGFR, so the decline is slower for kidney functioning, versus the best supportive care arm, which is more of the downward trajectory on kidney functioning. So you can actually find those estimates in the supplement. We've published the estimates at different sort of mile landmarks in the model, and those are available if you'd like to review right now. Next slide, please. All right, so this is where we start seeing the inputs and their effects at the later stages and the earlier stages. In order for us to calculate QALYs and EVLY, we use health utility scores. So remember when I explained in stage 1 and 2, we're really in a stage where we're really in those early stages where the asymptomatic nature of the disease is still happening. Then we see the decline start at 3A, 3B, until you get to dialysis, and there's a really severe impact on quality of life. If you look at the bottom row, that's the last thing really to note, where oral steroid use has a pretty big impact and a disutility on patients' day-to-day living. A lot of people, if you've ever been on steroids, I think can speak to this. It is pretty significant. That's only applied in the comparator arm. So we're applying that adverse effect in the comparator arm. Next slide, please. All right, so these are the treatment costs. The first thing to note is that atacicept is a estimated net placeholder price based on sibeprenlimab's estimated net price. We're just using the same for both of those. I'm going to point this out again in the results to remind you. The Nefecon treatment cost, even though it's a year or it's over the course of 1 year, those costs are reflective of a 9-month treatment course. And those are about $134 for that 9-month course. Next slide, please. All right, so the important thing to point out here is that we have this no specific therapy up top, and then we have systemic steroids in the middle row. One thing you'll notice in the first 3 stages, there's a differential cost for steroids. That's not actually the cost of steroids or the price of steroids. That's the cost of the adverse effects on average associated with being on steroids. So we're explicitly modeling that in the comparator as an adverse effect. The last 3 rows describe those downstream states that I had mentioned in the model schematic, the very burdensome dialysis. Medicare has a policy where patients that start, since this population is about mid-40s, they start in a potentially commercial plan, and then they transition over the course of about 30 months into Medicare. So we actually model that dynamic specifically. The last thing to note, transplant episodes, we were not able to get a cost. That is reflective of a charge. So there could be within that bucket of the transplant lower net costs that are not explicitly modeled. It's very difficult to find something like a cost to charge ratio. Next slide, please. So mortality is another really significant impact to this population. You'll first see there are increases in mortality in some of the earlier stages like 3, 4, and 5. And then it really starts to add up when you look at dialysis and transplant. And that data comes directly from the US renal data system. Remember when I mentioned steroids have adverse effects? We also model the potential increase in mortality in the first few stages of using steroids. That is modeled again only in the comparator arm. Next slide, please. All right, let's see how this all shaked out then in the results. So I'll have you first start on the far left-hand side. I'll repeat it again for atacicept. This is just the placeholder price that is the same as the estimated net price for sibeprenlimab. You should notice a pretty big difference in the cost for sibeprenlimab and atacicept compared to Nefecon. That reflects the duration of therapy. So we're using over all the way until we get to end-stage kidney disease, we're continually using sibeprenlimab and atacicept. For Nefecon, that's only the 9-month treatment course. So that's really the important piece to show there. Then in the middle, you see these non-intervention costs. This is dialysis, transplant, unrelated medical costs, mortality costs. They're quite substantial. If you start at the very bottom row, that's the baseline systemic glucocorticoids. That's going to be your baseline. Then you see in the top 2 rows, pretty substantial cost offsets from using sibeprenlimab or atacicept, again, at the placeholder net price for atacicept. For Nefecon, there are still cost offsets, even though we're only applying the effectiveness for 2 years. So there's still some of that. And then there's also the dynamic of the steroids having the higher adverse effect costs. Then if you look at the total sum in the middle, that's just a function of both of the acquisition and non-intervention costs. All right, now scroll all the way over to the far right. These are all modeled intervention effects, along with the costs, of course. We only have a few years of data that we're using. Just have that discussion right at the end in the Q&A. We don't know what's going to happen over the long run. These are potential treatment effects, but they are quite substantial. These are pretty big in terms of, for example, 5 perfect years of life or healthy years of life compared to steroids for sibeprenlimab and atacicept if those benefits remain. 6 years of life years gained compared to steroids, again, if those results remain. And then that middle outcome of time to end-stage kidney disease, about 10 years of an extension. We also see from the short-term use of Nefecon benefits, even though it's over the 2 years, we still see some of those benefits accrue for patients over that time horizon. Next slide, please. All right, so when compared to steroids, we are seeing that despite these substantial health benefits, ICERs are, or incremental cost effectiveness ratios for all of these, are substantially higher than commonly cited cost effectiveness thresholds. For sibeprenlimab, using the estimated or the placeholder price for atacicept, we see the same. And then for Nefecon, we see those small benefits and that small upfront cost, or that upfront cost, excuse me, meets the upper end of the commonly cited cost effectiveness thresholds in the US. Next slide, please. All right, so we did a number of sensitivity analyses. This one is an example where we take individual inputs, we vary them, and then we see the result, how much it changes. And this one, for example, I'll just give you an example. For the treatment effect, this is the biggest driver of the model by far. You can see just the width of the bar is pretty massive. The bar on the left-hand side that almost reaches to that 500,000 but doesn't quite get there, that's more of a flat slope of EGFR. So that's, in a sense, pressing the pause button for as long as we can in the model, but we still don't quite break 500,000 per EVLY. Next slide, please. All right, so if we vary all of our inputs in the model, we simulate 1,000 times, and then we calculate the number of iterations of the model that meet these different thresholds. That's the exercise that we're doing here. We didn't find any for sibeprenlimab, or using the same placeholder price for atacicept, we didn't find any either. For Nefecon, we found about a third met the upper end of commonly cited cost effectiveness thresholds. We would have expected that to be closer to 50%. And I'm going to kind of explain with a scenario on the next slide that we would have expected that. And I think it's just a function of a lot of different sensitivities in the model, in addition to the comparator, which also has its own sensitivity. So if we go to the next slide, I'll explain in more detail. So I'm showing you the base case, the modified societal perspective, no specific therapy. None of those are really going to change our conclusions. We found very consistent results across these scenarios, really as expected. The far right, I think, is one of the more interesting ones, where we take the side effects that I explained from steroids. So I highlighted those throughout the inputs. If you remember, quality of life, the detrimental effect, the increase in the adverse event costs, the increase in the mortality. You start seeing the lower end, if we apply for 2 years, versus the upper end applying for a lifetime. You see probably the most interesting scenario is Nefecon, where it goes above that 150 and above that 200 and to about 250,000 per EVLY. And then if you do the upper, where the lifetime steroids have a lifetime effect, it becomes more effective and less costly. We would call that a dominant scenario in cost effectiveness. So that's quite interesting. Hopefully it leads to some discussion. Next slide, please. All right, so as part of this analysis, we calculate health benefit price benchmark. So prices that would meet the thresholds that I've been speaking about of 100 and 150,000, both per quality as well as per EVLY. For sibeprenlimab, we found anywhere between about 60 to 80,000 per year. That's about an 80% discount off of the WAC. For atacicept, it is a placeholder price. It's going to depend on the net price. Very similar in terms of it's about 60 to 80,000. For Nefecon, as expected, we already have a price that meets these thresholds, at least for our deterministic result. I already explained to you some of the sensitivity analyses and scenario analyses and how those could change. Next slide, please. All right, so we had a number of limitations. I think I already spoke about the treatment duration and durability quite a bit. We don't have patient-level data, so we do thank one of the manufacturers for submitting that. We don't really understand completely all of the heterogeneity in patient movement through kidney functioning. So I think that really would be important with more data. I already spoke about the charged amount, so I'm going to move ahead in the interest of time to the next slide. All right, so there's been a lot of updates, in the draft evidence report, it says we, but I incorrectly applied an on-treatment transition for steroids for the lifetime of the model. This really, I think, is a benefit of the model transparency program. We had 2 manufacturers participate. They pointed this out, and we updated it. It's a really key feature of ICER's transparency, so we thank them for helping us with that. We also have new price estimates for sibeprenlimab. All to say, our focus today is on this updated evidence report, not the draft. Next slide, please. All right, so to conclude, a single course of Nefecon is more expensive but more effective than steroids, meeting that upper bound of commonly cited cost effectiveness thresholds. There was that uncertainty that I spoke a little bit about, especially considering the comparator is steroids. For sibeprenlimab, there are really some substantial life extensions and improvements in quality of life, but at that estimated net price, we just didn't see any commonly cited cost effectiveness thresholds that were met. They were quite a bit higher than that. And then, of course, for atacicept, it's a very similar conclusion, but it depends on the actual price. But if similar to sibeprenlimab, we would also see that exceeding cost effectiveness thresholds. So I think the next slide, we move to questions. Thanks for your attention.
Great. Thanks so much, Brett. We'll jump right in with Jeff.
We heard that it's probably in real life going to be a much longer term treatment with the Nefecon, that it's not going to be a one and done, but it'll either be retreating or chronic ongoing. What will that do? What would that do to the potential cost effectiveness? Because you're assuming a 9-month treatment, but what we're hearing is, yeah, that's what they did in the study, but it probably would not be used that way in real life over time.
Yeah, if you start applying, you have to apply both the treatment costs as well as the effects. So you're going to start seeing the ICERs increase over time, similar to sibeprenlimab and atacicept. The challenge is, how many courses are you going to do? So is it going to be 3 or 4 courses? There's a lot of variability in those results. So it's a really good question, but it's definitely one of those that it will look more like sibeprenlimab and atacicept because we have to keep applying those costs over time.
Rita.
Thanks so much. I mean, I'm still, obviously it's a model, but you modeled quality of life years gain when we had no quality of life data and we have a very uncertain progression. So can you give us some sort of estimates of certainty over those? It seems really hard to model in the absence of data.
Yeah, no, it was really difficult. Just to clarify, we do have quality of life estimates for IgA nephropathy that we used. There were a few different sources in the literature that helped us with that. So in terms of quality of life directly.
But from the trials, I didn't see any data collected.
No,
the trial that did collect data on quality of life did not show any benefit.
Yeah, and so really how we're modeling quality of life is the indirect effect of not moving downstream into those later states. And that's the evidence that we have on quality of life is really by kidney functioning in the different states. So the treatments and how we modeled it was if you were to delay progression into those, that would lead to the improvements in the quality of life. That would lead to the improvements into the reducing mortality, cost offsets, et cetera.
Just my last, like I thought Jason said it was 15 to 20 years on average from diagnosis to progression to end-stage kidney disease, but I saw 6 years for the glucocorticoid estimate. So I was wondering how it dropped from 15 to 6.
Well, yeah, those are average estimates. What we took was the placebo arm of the trial for Nefecon, and that's direct transitions from the evidence found in that. So that was actually submitted by the manufacturer. I think there is probably a lot of uncertainty around what the disease course looks like currently. I don't have a direct answer for you. Maybe one of the clinical experts can chime in that is that reflective of the trial, sorry, of the current state of IgA nephropathy.
So the faster progression was supplied by the manufacturer of the.
Correct.
Got it.
Jason, did you want to answer that, or you have another question?
I guess I just wanted to chime in very quickly that I wanted to make very clear that the numbers I presented in my presentation are highly uncertain. There's a lot of uncertainty about.
You made that clear.
Yeah, okay.
6 just seemed fast to me.
Yeah, no, I see the discrepancy as well, but yeah, thank you.
Rena.
Just a quick question about the costs with transplant. Does that include cost of living donor transplants? The cost for the evaluation, the surgery,
it's a good point. It's like a package cost, which made it difficult to have a cost to charge or a net. Like you can't just apply a cost to charge ratio to that because part of that bucket is the actual kidney itself and the donor and the process. So it essentially made it impossible to get a cost, and we had to use what was a charge. But you're right, it's like a bucket of all of the expenditures related to a kidney transplant,
including the donor, if it's a living donor.
Correct. Yeah.
Okay. Thanks.
Okay, thanks. Say.
Yeah, I have a couple of questions, Brett. First of all, a great presentation as usual. The first one was how much of the QALYs and EVLYs were driven by ESRD versus CKD3A, 3B, 4. And again, this is, I think, riffing off on Rita's comments about we have data for like 9 months, 15 months, 24 months, and we're extrapolating out to 15, 20 years. And so the uncertainties, I feel like, makes me very nervous that we think we have numbers. So it makes us feel like we know things. And I really have questions about how much do we really know?
Yeah. No, I mean, first of all, we're not shying away from that. I think it's a really important point that we really only have a few years on this, and the trajectories change over time that we see in the trial, and they bounce around. I think what we tried to rely on were clinical experts who helped us. What are the realistic trajectories? And yeah, you're right. We don't have years of data, just like we don't have years of data on effects on a lot of drugs that come to market. And this is no different. So I think it's a really important point. I wish I had like an answer for you, other than we tried to model a variety of different scenarios. The lower and upper bounds are going to be really important on the confidence intervals. So if you see from the trial, the upper bound, meaning the gap between the comparator and that drug is the widest, it's the biggest, that's going to be more of your flat slope. At the lower end, where we're closer, that's going to be more of a decline in that slope. So hopefully that helps you understand the bounds of truth that we're working with.
Great. I mean, one of the things that as a geriatrician, I was thinking about is whether I was a little bit when I was struck by when you said, these medicines press pause on EGFR declines. And I was thinking one of the concerns I had was that there are age-related declines in EGFR. There's a reason why, the largest growth of CKD2 and CKD3 are in like the 80-plus-year-olds. And so I'm not sure, I'm not sure whether it would help or hurt because obviously even if we press pause from the IgA pathology, I would expect that age-related declines would continue to occur. And I'm not, so I was wondering if you were able to account for those declines in your modeling.
Yeah, no, it's a good question. We did not have any sort of modifiers late in the model, but you have to remember that as you get to that level, to that age, you get into this weird competing risk problem where the just natural mortality of persons of that age increases quite dramatically. In addition to the CKD related mortality. So you're in the end, it becomes more of a mortality issue later rather than just the decline in kidney function. But it's a really good point.
My apologies. This may be more for Jason or for the clinical experts. I was wondering whether again, we're talking about things kind of continuing for a long time, or whereas the modeling, we only are, treatments for 9 months, et cetera. Is there any evidence or any concern about rebound effects? We're talking about if these drugs work, then it's going to slow down. But I feel like in a lot of diseases, when the medicine stops, we not only see it go back up to previous, sometimes it overshoots, and actually there's a vigorous re-inflammation that can occur. And I was wondering if there's any evidence of that for any of these medicines.
John or Shika, do you want to comment on that?
So the data we have to date, if we stop disease-modifying therapies, so this applies to complement inhibitors and B-cell directed therapies, is the proteinuria and the biomarkers return to where they were pre-treatment, and the rate of loss of kidney function returns to the rate that was observed before the treatment was started, or that was observed in the placebo-treated group. So there doesn't seem to be an acceleration of the rate of loss of kidney function when you stop these agents, although the data we have is relatively limited.
And so, and I guess that's Say's point. It is very short term. So do you have concerns that might change, or your best guess is that it won't?
My best guess is it won't. I can't think of a biological reason why it would alter the fundamental immunology of the disease. What we're doing is inhibiting cytokines, APRIL and BAFF, for instance, and when that is taken away, they will go back to normal. So I don't see that this will permanently accelerate the trajectory of the disease if we were to stop these therapies for some reason.
Great, thank you. Jeff.
Thank you. Congratulations, Dr. McQueen, to you and your team on modeling something rather challenging with challenging ingredients. And I just wanted to make sure I understood. I believe you touched on this, but I didn't quite get it. So I wondered if you could walk me through to clarify my understanding. I think in the report on table 4.5, you tell me there's about a 33% chance, there's a 1 in 3 chance that Nefecon is going to be cost effective at a $150,000 threshold. So I understand that. And then earlier, like on the previous page, it says that the ICER is about 150,000, 151. Yeah. So, and I think you touched on that, but I just wondered if you could explain to me how the expected value is about 150. Yeah. But if I'm willing to pay 150, there's only a 1/3 chance. Is it something to do with skewness?
Yeah, and it's a good question. I did touch on this in the presentation, and a lot of it, and you'll also see in some of the other results, which we haven't really touched on, a lot of this is due to the comparator and the sensitivity around the comparator. So how much are the adverse effects impacting that population? If not at all, then you probably have a less of a chance, right? If a lot, then you have a greater chance. And I just think a lot of that was the sensitivity around those parameters. I mean, we got wide sensitivity around the impact of steroids. Almost every physician I talk to, including those are experts, everybody hates steroids. They don't want to be on steroids. It impacts their quality of life. You can't sleep. There are cost adverse effects from cost. So that's why we focused on that scenario and showed that Nefecon had this wide range, wider than the other two treatments. So I think that's actually the anchor, is you didn't see such a huge change in the top two rows, if you remember that, but you saw a really big change with Nefecon. So that's the key driver behind why that's so sensitive and why we only saw a third.
So this is how the uncertainty is showing up big in the economic model.
Exactly.
Thank you.
Great question.
Great. Thank you. David, I think you get the last question or comment.
Really, I just wanted to comment on a couple of the things that people have asked about, because I wanted to add some information back. One is it may be 10 to 15 years or 15 to 20 years from diagnosis to end-stage kidney disease. But remember that the population Brett was modeling was the placebo arm of people who were entered in a clinical trial of a drug that won't have been started at the moment that people were diagnosed, right? It's not like most of these patients will have been diagnosed and instantly enrolled in the trial. So of course, you're going to be at a later stage of the disease, and you can see the distribution of disease there. And whether you think that will look just like what would happen in clinical practice, or whether, particularly with the newer therapies, there'll be a shift to starting them right after diagnosis, those are things that could occur, and it could have effects on how much you trust the model or not. But that's what's going on, I think, mostly with the model. In terms of surrogate outcomes and decline, I would just urge people to distinguish between proteinuria decrease, which we are hopeful means good things will happen to GFR over decades, and GFR decline, which we understand pretty well how that will relate to end-stage kidney disease over time if that decline continues. It's still a surrogate outcome, but it's a direct measure of loss of nephrons. And in the case of Nefecon, we actually have data on GFR decline in a way that we don't yet, but will for the other two drugs, where those data are being collected but have not yet been released, and that's why Nefecon got full approval. And then finally, just to defend poor Brett with all of this, remember that the alternative to modeling this stuff out and making the sorts of assumptions that we have to make is the situation we're usually in of people pulling the price out of thin air based on nothing. And so, yeah, there are uncertainties in the modeling, but the alternative is worse. It's really important to remember there are uncertainties in the modeling, to look at the sensitivity analyses, the scenario analyses, but you can still get a pretty good sense of what's going on here in a way that you wouldn't if you just said, well, manufacturer, should this be $300,000 a year? And they go, yes.
I'm not sure
think
the
that's
uncertainties or the alternative is worse, because I know we're making our best estimates, but they're very shaky, and it could be totally wrong. So I think it's best to be informed by data.
I think there's a difference between wrong and totally wrong, because we certainly know that with Nefecon, for a period of time, there is a decrease in loss of nephrons. And you can project that out as stopping to get the decrease of loss of nephrons after 2 years, which is what Brett did. And that gives you a sense of price for what did you get over a lifetime, having gotten a separation, and then the slopes become the same. Unless you think that for some reason there'll be acceleration back, and we've had lots of models where we included that possibility, I think we're in the range of a reasonable estimate. In 30% of these, the drug was cost effective, varying all these things. So there's lots of uncertainty here. I don't think there's as much uncertainty as when you don't model it. But
Sure, but we don't know about adverse effects. We don't know if everyone's going to get overwhelming infections and die if they were on it for several years. I mean, there are a lot of things we don't know.
I think if you continue, I agree with you. I totally agree.
Just for the interest of time, this is actually a great segue into the next comment. And there are always unknowns, and I think that's partly why the panel's here, is to take into account our best estimates of what those might be and how that impacts what we're thinking. So I'm going to send it back to Sarah, who's going to talk some more about modeling.